Good afternoon. I think I'm the last speaker. This is the second symposium to be the last speaker. Other thrombosis, Dr. Adel was the last speaker. But actually, to begin, I'd like to thank Professor Yaoub, who invited the Egyptian Society of Cardiology, and most of the Egyptians now, he come back to his country. He's already in his country. We send a lot of patients, Dr. Yaoub, in London. He did a lot of cases. It's a long time, and he came teaching a lot, but now he's doing a great job in Aswan Heart Center. And thanks for all the group with him, Dr. Wael Ablael, Dr. Ahmed Al-Gendi, Dr. Ahmed Afifi, and I'd like to thank Scientific Committee, Dr. Robert, to them. Dr. Magdi asked me to have a symposium on the Egyptian Society of Cardiology on a title, Unstable Plaque. So I think we started with the lipid projects with Dr. Ashraf, and then characterization, Dr. Magdi, then come to the clinical aspect. These are the biggest clinical trials, clinical or registry. So look at the registry called ACCESS Registry, Acute Coronary Syndrome Events Registry Strategy. Before we start, actually, Egypt has been developed in the last few years, and this is the review article, European Heart Journal, Cardiology in Egypt is improving through increased links with Europe and US. I think this is a very important issue. Now I link it a lot to the European Society of Cardiology and the American College of Cardiology, and most of the conferences are joining with them. We have ACC, European, in our conferences, and the same in Europe and the United States. So we are now making also projects with both countries, and I think in the future Egypt will come up even after the problems in the revolution. But actually we're going, even this conference is done while in Tahrir there is some form of revolution, but we are doing a job, I think, increasing rapidly. The agenda, what is the ACCESS global results, and then we take that ACCESS Egypt results, and this is the main conclusive difference between ACCESS Egypt versus ACCESS global. This is a lot of workers with the ACCESS registry. On behalf of ACCESS investigator, I did this, and this is, I have the honor to present this in Sweden, European Society of Cardiology, in clinical trial sessions, ACCESS Acute Coronary Syndrome in Africa, Middle East, Latin America, and ACCESS registry. And then this is published in American Heart Journal in November 2011, and now in press for the European Heart Journal. These are the participating countries. The 12,000 patients included worldwide. Egypt included 1,700 of these. Is the most big number, like Magdi said. We have a lot of patients, so we included 1,700 patients. A part of Egypt was part of Africa, it's not part of the Middle East here. The number of centers, 6 to 200 centers per country, 25 patients per center at minimum, 19 participating countries, about 600 sites. The primary objectives to evaluate the risk stratification, current management, and one-year outcome in patients with unstable angina, non-ST elevation, and ST elevations. Then the exploratory objectives to evaluate the impact of socioeconomic parameters to this management, to income level, insurance, educational level, and locations, and evaluate the impact of socioeconomic parameters in one-year outcomes, or including income level, insurance, education level, and locations. Then secondary objectives with medical practice, obtain data on the use of intervention strategies and its effect on clinical outcomes, to evaluate the direct medical costs at 1 year, then predictors of mortality. And these are the ACCESS results. 9,732 acute coronary syndrome patients with 1 year follow-up. Discharge and diagnosed ST elevation 45%, non-ST elevation 52%, a non-ST elevation 24%, unstable 28%, Middle East 38% of these results, Latin America 43%, South Africa 5%, and North Africa 14%. The baseline characteristics, actually there's an overall, the men is 74 here, mainly men. There's no difference between ST elevation and ST. Regarding the myocardial infarction for the medical history is an overall 22%, family history, 32%, actually the PCR, the small percent. Regarding the risk factors, diabetes constitute about 30, but treated, untreated. The treated was 59 and treated was 84%. The class 1 obesity is 21%, obesity is 7. Actually, the alcohol misuse is small percent in all these countries. Regarding the medical antecedents with angina, it's more in unstable angina than ST elevation infarctions. For the lab, there is no difference in serum creatinine, low density protein, and left ventricular ejection fractions. Look at the medication. All of them are taking about 90% of these patients were taking aspirin, statins, even 80% beta blockers, astonishing, are taking 65% taking ACE inhibitor in all groups. Regarding the in-hospital antithrombotics, mainly unfractionated, enoxaparin, unfractionated, and low direct thrombosis, we don't have either low molecular small number. For the coronary angio, it's 58% of these patients, but astonishing, 60% of these patients, ST elevation infarction is not reperfused. Only 40%. On medication discharge, they follow the guidelines, aspirin, statins, beta blockers, ACE and B, 70% taking thiamipridines. Regarding the deaths at 12 months, actually in death populations, in 7.3% mortality in all acute coronary syndromes, mainly ST elevation 8% and non-ST 6%. The most important the cause of death may be due to ST elevation, mainly in Latin America here, is 9.9%. And second is North Africa, third is South Africa, and the Middle East, 6.6% in the ST elevation, and all of them is 6% death. The cause of death will be unknown in 13%, 16%. For all of them in fatal myocardial infarctions, 45%, and less with the fatal strokes and non-ST. Regarding the survival curves, ST elevation was 94% and non-ST elevation is 96%. Then we studied the cause of death, either the for ST elevation, non-ST, and all. We found that the cardiovascular deaths in mainly here for all, actually for non-ST elevations, the combined endpoints with including non-fatal strokes, bleedings, and because of the bleeding is more here in these patients non-ST elevations. The main factor associated with 12 months deaths was found mainly cardiac arrest, is 9%. Cardiogenic shock is 5%, stroke and TIA is 3%, and age more than 70 years is 2%. These are the main factors associated with 12 months deaths. Then after 1 year, we took our data, our own data, Egypt data. So in 1,759 patients enrolled in 53 sites in university, governmental, and private hospitals. The first patient enrolled is 2007, and last patient was 2009, database locked on September 2009. And these are the ACS diagnosis confirmed. In 41% of these patients, ST elevations, in an unstable 37% and a non-ST 19%. Regarding the demographic, there is no difference in age. Even the weight here is the same, 87% for the mean, for the kilogram. The body mass index is 30, the waist circumference is 73%. The employment state, this is the most full-time job was found in 47%. Others part-time disability retires, only 50% full-time job. Educational level, only colleague university is 43%. The others at primary, secondary levels or none. The health insurance covers in governmental is 39%. And the others are private, governmental and privates, and not covered in 34%. This is very, very important number that only 39% is only governmental. Regarding the risk factor non-ST elevation, as Dr. Ashraf and Dr. Magdi, they said that diabetes, hypertension, dyslipidemia, and smoking states. The most important is hypertension in Egypt, is 67.9%. The second is diabetes, is 50%. Then dyslipidemia and smoking the same. It's not smoking first, but hypertension is the main. The same here for the ST elevation. Hypertension is 50%, and then secondly, here for ST elevation, you found it astonishing in ST elevation, smoking is most important. The third is diabetes, and so it's favored that diabetes may be a stable, diffuse disease producing unstable angina, but smoking producing acute ST elevation infarction, and that's why the most common risk factor together with hypertension. On admission in unstable patients, 95% with symptoms, ST elevation 97% symptoms. Regarding the time to admission to hospitals, actually 14.6 hours. For laboratory tests, there is no difference in creatinine, LD, cholesterol, glucose, and hemoglobins. There is no difference in laboratory tests. Regarding the intervention, only 35% angiogram. Unstable patients is 995 patients. Medical management is 78%. Only 22% of these patients go to PCI. On the first day in hospitals, it's about 80%, 37%. With these patients, without stent 3%, but mainly with the stent. So 22% of unstable going to PCI, most of them with stenting, mostly 74% with bare metal stent in our country. For ST elevations in all patients, medical management in 71%. For PCI, only 28.8%. With the stents is 95.8%. Bare metal stent is 75%. So in evaluations 3 of unstable patient and 0.8 of ST elevation, there went an exercise tolerance test after. The result positive in 55% of the patients. Regarding the outcomes, comparing Egypt with the Middle East, Latin America, and Africa, we can find that recurrent ischemia, unstable non-ST, is 17% in Egypt, more than maybe incomplete treatment of these patients unstable angina. The same for the regional difference in mortality for Africa, Latin America, and the Middle East. Africa is 1.4%, Latin America is 2%, Middle East 2%. Regarding discharge, actually with the same guideline, the aspirin, unfractionated heparin, patients, statins, insulin. Then regarding the 1 year follow-up, the survival at 12 months is 90%. For the all cause of death at 12 months, survival analysis by diagnosed subgroup is between 90 to 92%. Regarding the cardiovascular outcome over 1 year, the unstable angina is 35%. In patients either with ST elevation and ST elevation here, the cardiovascular outcome. Regarding cardiovascular outcome leading to hospitalization over 1 year, mainly due to unstable angina and congestive heart failure, because these patients are only for medical treatments. The cardiovascular surgical outcome at 1 year for PCI, 35% CABG in only 10% of these patients. Then we come to finalize the major difference. This we have our data and the other worldwide data. What is the major difference? Age of Egyptian population is below the average of other countries, it's 10 years less. Diabetes, mellitus, and hypertension as risk factor to be compared with other countries. Smoking independent risk factor, it is showing a significant effect on outcome or not. The number of investigators and their geographical distributions, including private center versus public centers. Although we are stick to the international guidelines in management, but we're still going to conservative approach more than intervention. Maybe this is reflecting clinical outcomes. Can we conclude this based in this point? And so we need to emphasize the role of intervention. That's why we started Stent for Life projects. Then we come to first difference. The age of Egyptian population is below the average of others. This is the age in Egypt, age in global. 57 here the mean, but 61 non-stable angina, 54 in 58. Regarding the diabetes and hypertension here is in non-ST elevations is 3.8 in population, but in Egypt is more. So in Egyptian populations, more diabetics, but there is no difference in hypertension. For ST elevations, actually diabetes here is the same, hypertension is the same. So it's mainly difference in non-ST elevation that the diabetes is more than in other populations. The third question, smoking. Smoking independent risk factor. You can compare smoking status for non-ST, ST in different populations and Egypt. Actually in Egypt it's more, both in non-ST and ST elevations. The fourth variables, the number of investigators and geographical distribution, including private center versus public centers. This is the non-ST intervention for Egypt data, actually is less. In conservative approach, it's more. For ST elevation is less, and conservative approach more or less the same. So, Mr. Chairman, my colleagues, this is my conclusion. In this multinational observation study of acute coronary syndrome patients, use of evidence-based pharmacological therapies, acute coronary syndrome was quite high, but reperfusion rate is 40% for ST elevation. These were disappointing low. So these findings suggest opportunities to reduce further the risk of long-term ischemic events, acute coronary syndrome patients in developing countries. And overall, acute coronary syndrome access registry occur in young patients, less than 65, mirror higher prevalence smoking diabetes, manage more conservative low intervention rates, treated with less expensive drugs. Treatment of these countries is characterized by frequent use of drugs, stents, particularly these patients going to, usually these patients going to private hospital to do primary PCR, that's why they're using drug-eluting stents. Wider use of statins, antiplatelets, use of beta blockers, ACE inhibitors associated with improved survival. Treatments follow the international practice guidelines, but mainly conservative, but acute coronary syndrome are associated with low in-hospital mortality. So, we decided after the access, the national project should be mandated for patient and physician awareness, very important to have the guidelines for the patient and to aware the patient about the acute coronary syndrome, emergency awareness, cath lab availability is 24/7, collaboration between Ministry of Health, Health Insurance, and social payers. So at that time, we decided to find the way, and this is the declaration of the Stent for Life project with the Egyptian journey in primary PCI. So we started at that time to have part of the Egypt part of the Stent for Life project. And thank you very much.
For this information. Thank you very much. One thing about the Stent for Life project, there are other centers that have a very high volume of cases, and I hope that in the future, the very near future, that they are included in the project for the welfare of our...
Tomorrow I'm going to speak about the Stent for Life project.
Yeah, okay.
But regarding the question, the answer of this question, yes, we started the first phase registry, and according to the first phase registry, we found whole centers, usually at the beginning they're so enthusiastic to use the data. So depending on choice of the center, you should go into the registry, and then you should have the cath lab availability 24/7, not only the volume, but you should be a candidate for doing this patient at the midnight, not going in the working hours only. So in order to choose that center differs from the high volume on the center.
Okay. Another issue about the sponsorship by the Ministry of Health. I don't know, Adil knows about this problem because the amount of money sent by the Ministry of Health now got back to the initial amount, 6,500 pounds, something like this, not the 10,000 that they agreed about.
No,
yes, the ministry is not complying really to what we agreed on, that it will be a bigger amount of money, so we'll be allowed to do some thrombectomy aspirations and some use of 2B3As, and so we increased the amount of money. This is a problem, I think we will discuss it tomorrow in the Stent for Life project, about the problems of implementation of Stent for Life project in Egypt. Okay. So I think tomorrow we'll have more time.